First up is Dr. Gaurav Nigam, who is, as stated, NIHR Clinical Research Fellow and Senior Training in Gastroenterology, looking on some of the details in the very excitingly named Experimental Medicine Division at the University of Oxford. And he's going to talk to us about some of the work he's been doing in his research about improving transfusion care in acute upper GI bleeding. Over to you, Dr. Nigam.
Thank you. Thanks for the invitation to speak today. Today I'm just going to talk about improving transfusion care in patients with acute upper gastrointestinal bleeding. As gastroenterologists, this is a very common medical emergency that we are involved with, and transfusion forms an important part of care for these patients. Just a bit of background. So as mentioned, GI bleeding is a very common medical emergency with over 50,000 hospital admissions annually across the UK. As a clinician, it can be quite challenging to identify these patients, and especially to risk stratify them, to identify those who are at high risk of dying or to prioritize those who require urgent treatment. They're often seen by a multidisciplinary team ranging from acute medics to emergency physicians to gastroenterologists, and also require inputs from hematology for consideration of blood transfusion and transfusion of other products, and occasionally requiring surgery as well as interventional radiology. Of course, endoscopy is also an important part of the management for these patients. It is estimated that it costs over £150 million annually in the UK for management of these patients, with majority of the costs related to their length of stay, endoscopy, and blood transfusion. Given that this is such a common medical emergency, various initiatives have taken place to improve the care of these patients. Today in my talk, I'm just going to cover some of the past work that has been done to improve the care of these patients, leading on to the interim results from a UK-wide acute upper GI bleed audit carried out last year, and then look at potential solutions to improve the management of these patients further in the future. Going back, initially, the work began with a national GI bleeding audit to identify the scale of the problem, and this national audit looked at the incidence and mortality rates related to acute upper GI bleeding. The audit noted that with increasing age, the incidence and the mortality of patients with acute upper GI bleed increased. Once the problem was identified, some changes were made and feedback was given to the participating centers, and a re-audit was carried out after 6 months. However, little demonstrable changes were noted in practice, and there was no reduction in mortality between these two audit cycles. But this data set was used to develop a risk scoring system called the roll call scoring, which could help risk stratify the patients and predict those who were at a high risk of repeat bleeding or death after being admitted for acute upper GI bleeding. At around the same time, there was also a regional audit carried out in West Scotland with the aim to develop and validate a risk scoring system to identify the patients who required a hospital-based intervention. This new score, called the Glasgow-Blatchford score, has now been well established as a validated score for predicting the need for clinical intervention, and it can help identify low-risk patients which can be easily discharged without requiring to be admitted to the hospital for hospital-based intervention. Following on from this work, supported by NHS Blood and Transplant, in 2007, another national audit was carried out, which also looked more specifically into the importance of transfusion in patients with GI bleeding. Some of the findings I'll discuss later, but one of the things that came out of this work was the development of a cluster randomized feasibility study comparing the restrictive versus liberal thresholds for red blood cell transfusion in patients with acute upper GI bleeding. This trial divided the patients into two arms. One received a restrictive blood transfusion at a transfusion threshold of hemoglobin less than 80, and then the other was at a liberal transfusion threshold of less than 100. There were already some changes that were happening in clinical practice, and as can be seen in this graph, the numbers with liberal arm were the adherence was less to the liberal arm because clinicians were understanding that restrictive transfusion policy is better. So this study did not note any significant differences in clinical outcomes, but patients in the restrictive arm received less transfusions and had numerically less chances of repeat bleeding and a lower mortality. At around the same time, I think one of the initial presenters presented the NEJM study as well of restrictive versus liberal transfusion, which was published in 2013. So that also suggested that restrictive transfusion policy was better in these patients. And this was confirmed with this meta-analysis, which showed that a restrictive transfusion strategy was associated with a reduction in mortality. And the current guidelines suggest keeping a transfusion threshold at around 70 grams per liter. However, what's important to note is that these results may not apply to patients with comorbidities such as ischemic heart disease or if they have severe hemorrhage, wherein the decisions need to be taken based on individualized risk and the clinical judgment. Moving on from there, in 2022, we carried out another audit, which was supported by British Society of Gastroenterology and NHS Blood and Transplant. The need for the audit was thought because there have been significant changes in terms of service delivery and improvement of care with better availability of endoscopic therapy, availability of national and international guidelines. And also we wanted to use this data to clarify areas of ongoing clinical uncertainty, such as use of optimal risk assessment scores and optimal timing of interventions. One of the important aspects of this audit is also to improve patient blood management in patients with acute upper GI bleeding, with focus on individualizing a transfusion plan at presentation using this data, as patients with acute upper GI bleed often have multiple comorbidities and may have varying etiology for the cause of bleeding, namely varicose versus non-varicose bleeding, wherein the outcomes may be different. And I will come to that in some of the slides later on. We also want to identify the optimal timing of transfusion to streamline resource allocation and to reduce the burden on transfusion laboratories, as a lot of times these patients, when they come in with GI bleeding, they may require O negative blood, which may or may not be necessarily required. All NHS trusts in England, Northern Ireland, Wales, and Scotland were invited to participate in the audit, and patients were prospectively identified during a 2-month period in 2022. The case identification was carried out with the help of audit leads at all participating sites and included patients resulting in presentation to the hospital or if they developed GI bleeding while already hospitalized for another reason. They did not need to have a blood transfusion or endoscopy to be eligible, so that we could cover a wide variety of these patients. We included all patients above 16 and with suspected and confirmed upper GI bleeding. The audit tool was quite detailed with a lot of information that was captured. These were available as online forms to complete, or for the sites that wanted to complete a paper form, it was available as a paper form. And information was required to be collected from patients' case notes, the transfusion histories, which were available on hospital IT systems. It took about 35 to 40 minutes per case for completing all this audit data. Coming to the interim results of the first 4,528 patients, I say interim results because given the scale of this project with a lot of sites returning paper forms, we are still working through compiling the data set and working through the analysis, but these are the initial results. So there were 4,528 patients, with 83% of them being from England, 13% from Scotland, 3% from Wales, and 1% from Northern Ireland. Out of these, about 83% underwent inpatient endoscopy, which gives a number of 3,739. On the left, I've also highlighted the Glasgow-Blatchford score risk categories, which shows a good variation in terms of the low to high risk category patients with GI bleeding. Comparing the results with the 2007 audit, the patients currently in this audit were slightly older compared to those in 2007, had higher comorbidities. More number of patients were on anticoagulants at the time of presentation, and a higher proportion had chronic liver disease. Also, looking at the use of blood transfusion, it appears the use of packed red cell and platelets has gone up compared to the 2007, while for fresh frozen plasma, it appears that it's slightly lower than that compared to 2007. Looking at the overall mortality, there have been some improvements. So despite an older and more comorbid population, it seems that there have been improvement in terms of reduction in mortality of the patients. Next few slides will focus specifically on blood transfusion, and this is the subset of patients who underwent endoscopy, as these were the patients who were admitted to the hospital, and more information and detailed information on repeat bleeding, etc., was available for this group. So looking at the use of different blood products that were used for patients who underwent endoscopy, about 54% of these patients were transfused red blood cells, and more than half of that was given within the first 24 hours. The other blood products that were used included fresh frozen plasma in 6%, platelets in about 5%, and 2% PCC and 1% cryoprecipitate. Again, most of these requirements were within the first 24 hours of presentation with GI bleeding. Looking at whether the correct transfusion threshold was followed or not, we noted that only 46% actually had a hemoglobin less than 70 at presentation, with more than 54% having initial hemoglobin more than 70. When comparing the risk of rebleeding and mortality between those who received early red blood cell transfusion, that is within the first 24 hours, versus those who did not receive red blood cell transfusion in the first 24 hours, dividing them based on the initial hemoglobin category, we noted that if the initial hemoglobin was less than or equal to 70, which is the restrictive arm, the rebleeding and mortality rates were not significantly different if they received early red blood cell or not. While for initial hemoglobin category of more than 70, these rates were higher if the rates of rebleeding and mortality were higher if patients received early red blood cell transfusion in this group. When adjusting for the Glasgow-Blatchford score and initial hemoglobin levels, early red blood cell transfusion was associated with a 56% increased risk of rebleeding and a 42% increased risk of mortality. So probably there may be, as currently it's just the guidelines only mention about the transfusion thresholds, but the timing of transfusion may also have an impact, and that needs to be evaluated further. This graph here shows the rebleeding and mortality rates based upon different Glasgow-Blatchford score category. And as can be seen, the blue graphs are that for early red blood cell transfusion, while the red graphs are for no red blood cell transfusion. So rebleeding rates and mortality rates were higher in all risk category patients. Again, coming back to the results from the 2007 GI bleeding audit, these were similar results that were noted back in 2007. So it seems that with regard to transfusion, not a lot has changed despite guidelines suggesting following a restrictive transfusion threshold. Over here also in 2007, early red blood cell transfusion was associated with increased risk of rebleeding and mortality. When adjusting for the initial risk scores and initial hemoglobin, there was a twofold increased risk of repeat bleeding and a 28% increase in mortality. Given that there may also be an impact of the underlying etiology that can have an impact on the need for transfusion of different products, as well as the outcomes, we looked at comparing the blood product transfusion in varicose versus non-varicose upper GI bleeding. There were a total of 364 patients with varicose upper GI bleeding, with majority of the patients having non-varicose bleeding, which was 2,095. But looking at the proportion of blood transfusion, the proportion of different products required was higher in the varicose group. And again, this use was highest during the first 24 hours. Just a summary slide giving the outcomes of the patients between varicose and non-varicose bleeding, which just shows that these are younger patients who are sicker, requiring more ITU support, more endoscopy treatment, and also more treatment in terms of more blood products were required. And the in-hospital mortality was also higher in the group of varicose bleeding. Again, when comparing the early versus no early red blood cell transfusion between the two initial hemoglobin category, in patients with varicose upper GI bleeding, although if the initial hemoglobin category was more than 70, it seems numerically higher level of rebleeding and mortality is seen in all the groups, but there were no statistically significant differences whether they received early red blood cell transfusion or no early red blood cell transfusion. With the when adjusting for the Glasgow-Blatchford score and initial hemoglobin levels, early transfusion was actually independently associated with only a 5% increased risk of bleeding, with confidence intervals crossing 1, and a 26% reduced risk of mortality, with again confidence intervals crossing 1. So the question is whether the red blood cell transfusions are really required in the early phase, and whether there's also a suggestion that there could be alternative products that can be used. And I think again in one of the earlier presentation it was mentioned that HAS could be used in patients with variceal upper GI bleeding, or those who have got decompensated chronic liver disease. When looking for these comparisons for non-variceal upper GI bleed, clearly, if their initial hemoglobin category was more than 70, and if they were given early red blood cell transfusion, they had higher risk of rebleeding and mortality. This graph here just shows the comparison based upon the different GBS categories for rebleeding and mortality for variceal and non-variceal bleed. In terms of variceal bleed, it seems that for the medium and high risk category patients, rebleeding rates were higher compared to those in those who received early red blood cell transfusion versus those who did not receive it, while mortality was lesser. Again, this needs to be evaluated further, and this is something that needs to be looked into. But clearly, for non-variceal group, early red blood cell transfusion actually increased the mortality and rebleeding rates. Just putting it all together, looking at the timeline in management strategies for acute upper GI bleeding, as mentioned, there have been regional and national audits leading to development of national and international guidelines for management of acute upper GI bleed, with more recently development of a British Society of Gastroenterology-led multi-society care bundle for improving the care in acute upper GI bleed. And now we've come to the 2022 UK-wide acute upper GI bleed, which has helped assess changes and impact on the management. And it seems that the mortality rates have gone down, endoscopy therapy has improved, but in terms of transfusion practices, there may be further improvement that is required. Coming to the use of clinical risk scores in identifying patients, various risk scores have been developed in acute upper GI bleed, and this table just highlights the various, some of the commonly used risk scores and their main predicted outcomes. As can be seen, none of the risk scores actually look at predicting the need for transfusion, although some of them capture a red blood cell transfusion as a combined outcome, but not a specific outcome. And also, when looking at the prediction of specific outcomes, there is variability in terms of the performance of different clinical risk scores, suggesting that one risk score cannot be used for all different outcomes of interest. Current guidelines for blood transfusion are based on a restrictive transfusion strategy of 70 grams per liter. As mentioned, none of the current risk scores predict the specific blood transfusion requirements. And also, the transfusion needs continue to change in patients with acute GI bleeding based upon the initial management that they receive and during the course of their hospital stay. To solve some of these problems, one of the potential solutions may lie with machine learning. Machine learning is basically use of computer algorithms using large data sets to help with giving risk prediction or to propose optimal dosing of treatment. Some of the forms include supervised learning, where the goal is to predict outcome based on a labeled training set, and this can be used for risk prediction. Then there is unsupervised learning, which can help identify patterns or groupings and can be used in identification of radiology or endoscopy images. And then there is the reinforcement learning, which helps to optimize prediction by trial and error, and this can help propose optimal dosing based on feedback from previous experience and could be used in identifying the need for transfusion in patients with GI bleeding. Any good prediction model needs a good large data set, which needs to be divided into a training set, a validation test, a validation data set, and a test data set, which should ideally, the testing data set should ideally be geographically or temporally separate from the initial data set for external validation. The training data set is used to train the computer algorithm for the defined task. The validation data set is then used to fine-tune the parameters, and once a satisfactory performance is obtained, it is used to validate it using a testing data set. Machine learning has already been applied in the context of upper GI bleeding, with this group from Yale developing a machine learning based risk scoring system, which can outperform traditionally developed clinical risk scoring systems in identifying low risk category patients. They used some common parameters at the time of admission and develop machine learning algorithms to see if that can perform better than the commonly used risk scores to identify low-risk patients who did not require a hospital-based intervention or were not at risk of dying, and showed that it performed better compared to these other risk scores. However, again, when looking at individual outcomes of interest, the performances of different models may vary, and suggesting that there may be need for developing different models which can then be put together as a software package and can help predict the different outcomes of interest. The same group also developed machine learning algorithms to predict the need for red blood cell transfusion in patients with acute GI bleeding admitted to the intensive care unit. They used what is called as a long short-term memory model, which keeps updating its output during the course of the hospital admission by capturing new information that is made available to it and gives out prediction in real time. Again, they showed that this model was able to perform quite well when given the task of predicting the need for blood transfusion. However, there's more work that's required to improve the performance further. We've also done some initial work using the 2007 audit dataset, wherein we looked at using the pre-endoscopic variables and endoscopic variables for predicting the outcomes of mortality and repeat bleeding, and noted that they outperformed the currently available clinical risk scores. The aim now is to develop and test a decision support tool, which can be used by applying machine learning on countrywide data sets available from these audits and electronic patient records of patients presenting with acute upper GI bleed. This can help support clinical management, including transfusion practices and streamlined resource allocation. The primary outcome for any such decision support tool which would of course be to risk stratify and identify the highest risk category patients who require a hospital-based intervention or 30-day have a high risk of dying, while the secondary outcomes would include predicting early and late risk of dying, predicting need for specific interventions, risk of repeat bleeding, length of stay, etc. Just to picturize a well-developed decision support tool would look like something like this, wherein it's a software interface which captures the information of patients when they present to the hospital, captures all their clinical assessment, laboratory data, etc., and gives out prediction in real time for different outcomes of interest, and also provides an explanation for the features that have been selected for each outcome of interest. In summary, despite current guidelines recommending a restrictive approach to red blood cell transfusion, the 2022 audit has shown that a significant proportion of patients still received early transfusions with a liberal strategy. This early transfusion was associated with an elevated risk of repeat bleeding and mortality, again, potentially due to liberal transfusion, and this is similar to what was noted in 2007. A one-size-fits-all may not be applicable, and given that there are novel methodologies such as machine learning that is available, we can use it to develop clinical decision support tools to individualize transfusion strategies for patients with acute upper GI bleeding. At the end, I would like to just acknowledge the contribution of all the participating hospitals and site leads which have contributed to this audit, and also to the audit steering committee which helped plan this audit. Thank you.